Thank you so much. Good afternoon, and I'm very glad to be here. And thanks for the kind introduction, Cristina, and for the invitation. And I'm going to talk about the academic model for CAR T-cell development in Barcelona, in a hospital clinic, with focus in multiple myeloma. Here you can see my disclosure. I have to say that one is that I am the principal investigator in RE2H, and also I am a hematologist, and I am a clinician treating patients with hematological malignancies. Well, we are going to talk about CAR T-cells. Without doubt, we know that the treatment with CAR T-cell has changed completely the perspective of patients with hematological malignancies, particularly those with relapsed refractory disease. However, the procedure is a little bit complicated because we know that we have to send, in general, the cell after apheresis to a production center, usually outside the country, usually sometimes even outside the continent, and to produce, to wait for a slot, to wait for the time for production, for the quality controls, to administer a bridging therapy in the meanwhile, and finally to treat the patient if it's possible, the patient is stable and in the same condition that previous to the apheresis. With that, it's true that even with the impressive efficacy that we have, the many groups have shown in the treatment of acute lymphoblastic leukemia or several B-cell lymphoma or multiple myeloma, they are, one, expensive. There are still autologous products that we need all this network, all this time to produce. We have difficulties in product distribution with a large vein-to-vein time, but also with problems to access in several countries, and even a lot of heterogeneity in the same country. As example of the US, only a fraction of patients that can be candidates to this treatment finally receive it. And there are strategies of optimization based basically on off-shelf products, but they are still far of the clinical results as we have with autologous products. With that, the access to CAR T-cell therapies is still a challenge. And as an example, a courtesy, this is a paper from Julio Delgado, my colleague. We share the office. He is working mainly in the CD19 CAR T, RE1, but you can see here on your right that with the products, for example, for commercial product for multiple myeloma, even both approved by the EMA, the access is quite limited. In fact, except Austria and the country where we are now, Germany, there is almost a lack of access of ide-cel or cilta-cel to this in the countries. One point that I saw that was discussed a little bit earlier today, that is also about establishing your goal with when deciding to proceed with authorization or the clinical use with a CAR T. That the standard probably path is to this scientific approach, that you send a grant, request funding, you perform all the preclinical and clinical studies, and you publish in a wonderful paper. You can be promoted to professor, you get more money, and that is the circle of scientific life. However, and you can even license to the company and you receive extra points in your institution for transfer activity. However, but in the drug developer approach, it's true that the publication is a secondary objective. The main objective, usually it's important the contact with the regulator to plan your strategy ahead, all the legal aspect, the patent, etc. and to authorization application is probably the final objective as also the commercialization finally. And probably the scientific impact could be more limited. One strategy to improve the access to CAR T-cell therapy include the strategy of point of care, that instead of a centralized production with one or two manufacturing sites, to have a decentralized manufacturing sites in the hospital, very close to the patient, very close to the apheresis procedure. And of course, you have to guarantee that the different facilities and the clinical management is the same in all the network. The other point, you have discussed a lot about the key steps of the pharmaceutical development, but it's true, if as an institution you want to have a final product, you need all the steps, not only about the idea, of course, the preclinical and animal models to apply. You need exploratory trials, but you have also trials that was also discussed previously, to lead to an approval. And finally, even after the approval, you need a pharmacovigilance surveillance in your institution to guarantee that the risk-benefit is still stable after with the follow-up. Our first product that was described previously was our CD19 CAR-T, ARI1, Barnicel, that was established in the Prodigy system, and it was approved in the hospital exemption in 2021 for patients with older than 25 years old with acute lymphoblastic leukemia in a relapsed refractory phase. The price and the reimbursement was agreed with the Ministry of Health in Spain, and it was also obtained the prime designation by the EMA, and a phase 2 trial in several Spanish centers, and also a European trial is ongoing. That is now a little bit of the path of several years from the first antibody, all the preclinical studies, the clinical trial, the evaluation by the Spanish agency, and finally the approval. And we are still treating patients under this program, not only in the hospital extension, but also in compassionate use, because we have several B-cell malignancies. They don't have any approved or reimbursed treatment in Spain. But I am a myeloma doctor. It was one of my disclosures. And myeloma is instead of, for example, in comparison with acute lymphoblastic leukemia, the second most common hematological malignancy. And it's produced by the malignant plasma cells, and it's incurable disease. That is, in general terms, the prognosis of this disease. And it's a systemic disease because it's producing bone lesions, also anemia, infection, but also the patient can develop a renal failure. The landscape of the treatment of multiple myeloma has changed dramatically in the last 20 years. From thalidomide, after the proteasome inhibitors, the monoclonal antibodies against CD38, and more recently with CAR T-cells and biospecifics. And adding all these strategies, the prognosis of this patient have improved. In the last century, the survival of this patient was only 2 to 3 years, and now is 7 to 10 years probably. However, when the patient develops a relapsed refractory disease to all these strategies that we have now, that are mainly probably 5 main drugs, the prognosis is very ominous, and the survival is less than 1 year outside advanced immunotherapy. In this sense, we are the most established platform for the treatment of this patient are CAR T-cells. Even we have 2 biospecific antibodies also approved in Europe, and for example, with reimbursement now in Spain. B-cell maturation antigen is the main target, and we are very lucky that it's expressed very strictly in plasma cells and not in other tissues. And with the impressive results, even in very, very advanced phases, of the result from the National Cancer Institute, or also with the first result with ide-cel, we could see that the patient are able to respond, but also a very high quality of response, that it was very nice, that it was no partial responses, were complete responses, even patients with negative minimal residual disease. One of the first product that was approved is ide-cel. It's a murine anti-BCMA that was approved several years ago by FDA and EMA, but the reimbursement, for example, in Spain was this year. The progression-free survival with this is around 9 months. With cilta-cel, is a most potent agent because it's binding two epitopes in the BCMA, and the progression-free survival is beyond 30 months. And even they have to be a little bit cautious about some neurological toxicities. And I'm going to talk about cel, RE2H, that is a humanized anti-BCMA CAR-T with a 4-1BB co-stimulator molecule that demonstrated in vitro and in vivo also in a murine model that was very active. And after the evaluation by the Spanish agency, we got the approval for a clinical trial, initially in a first cohort of 30 patients. These results were evaluated by the agency, and they suggested to increase the number in a second cohort of additional 30 patients. Finally, we have 60 patients. The virus was produced in Barcelona. We also were the coordinators of the study. 2 centers produced the CAR+cells in Pamplona and in Barcelona, our hospital. And in total, at the end, 7 centers performed apheresis and treated locally their patients in several regions of Spain. Some of the main clinical features, we use the lentiviral transduced autologous T cells. We use, as we had that experience with 31, a fractionated first dose of 10, 30, or 60% of the total of 3 million of CAR-T cells per kilo. That was in 1 week. And that part that was completely new in our trial, that we plan to administer a second dose of up to 3 million of CAR-T cells positive per kilo after 3 months in patients without relevant toxicity and some degree of response. Here you can see the characteristics of the patient, of the 60 patients, with some features of high risk, like the presence of extramedullary disease. This is outside the bone marrow, high risk cytogenetics, a median of 3 prior lines of treatment, and with exposure of all the main regimens available in Europe. The main results about efficacy, we have 95% of overall response with almost 60% of complete response. If we translate that into minimal residual disease in bone marrow, that was centralized in Pamplona, and it's a reference center in Europe for that, we have a 98% of the samples and 96% at day 28 or day 100, respectively, show a negative minimal residual disease. The last update about follow-up is with a follow-up of 2 years, and we have a median progression-free survival of 20 months with a median overall survival that is still not reached. We could see also activity in extramedullary disease. It was one of the first patients, a patient from my clinic, that showed in the PET-CT an amazing and rapid response of all the extramedullary disease that in general is comparable to the bone marrow disease, even if the true hematogenous dissemination could have a worse prognosis. And in fact, we performed this multi-center study, including several German colleagues, and we saw that the extramedullary disease of the plasma cell leukemia are negative factor for the progression-free survival and the overall survival of these patients. About the second infusion, this second booster dose that we administer after 3-4 months, of the 55 patients that were eligible, 44 could receive it after a median of 4 months. We administered a second lymphodepletion in patients without RE2H persistent in peripheral blood. We didn't see any side effects in the booster dose administration. In fact, we are doing now that in the outpatient clinic. And the response was available in 42 of the 44 patients, and in some of them, even more of them were already in complete response. Some of them improved the response from partial response to BGP, very good partial response, or to complete remission. We have the problem with toxicities in general in CAR+cells, like CRS, neurotoxicity, etc. In myeloma, we have also cytopenias and infection that could be more important than with CD19, and also the delayed neurotoxicity of other specific neurotoxicities. And particularly one is the Parkinson's syndrome that could be probably more frequent with cilta-cel than with ide-cel, and it's a it's a very severe complication. In the case of RE2H, 90% of the patients had a cytokine release syndrome, but in general were grade 1 or 2. And we didn't have any late neurotoxicity events, and only 2 ICANS that were all grade 1. One of the problems is that we are, even the high response rate in myeloma, we are still, we're still seeing relapsing. Relapse after the treatment, and one of the, among many factors, is that probably the expression of BCMA could be reduced, even negative in a small fraction, probably 5 to 7%, but in general, the expression of BCMA is reduced after the CAR+cell. These are the results of our trial, for example. For this reason, other targets are in development. We are also looking for new targets. The first one, probably beyond BCMA, GPRC5D. I was very lucky to work with Eric Smith at the Memorial Sloan Kettering at that time with the development of the first CAR-T against GPRC5D, and also to develop this bispecific CAR-T against BCMA and GPRC5D that probably can reduce for a longer time the proliferation of malignant plasma cell, and can probably also delay the relapse, and even, well, hopefully we can cure some of these patients. In Spain, beyond this trial, we are developing this point of care. Now they say more than 90, now it's more than 100 patients have been successfully treated, usually in a compassionate use program. The cost for a compassionate use program is about 90,000 euros. We are trying to launch an academic European trial with RE2H, also with a point of care strategy, trying not to go to this valley of death when you don't have the centralized approval and it's a limited use for our patient. That at the end is our objective. We are very lucky because after the effort, you know that this trial started in the middle of the pandemic. We started in 2020, and after several steps, finally, this year, this August, we had the authorization, the National Hospital Extension Clause, for the treatment of patients with relapsed refractory multiple myeloma after at least 2 prior lines of treatment. That was the inclusion criteria in the trial, and with disease progression to the last treatment, and with exposure to the main regimen that we use in this disease. Beyond myeloma, we treated the first patient in the world with AL amyloidosis that's also produced by malignant plasma cell. This is a patient also from my clinic, and she's more than 3 years in complete response, and also with kidney response, the main organ that was involved by the amyloidosis at that time. We have been treating patients with myeloma in advanced phases. Now we're trying to treat in very early phases instead of autologous stem cell transplantation, or even in asymptomatic high-risk disease. And in our hospital, we are going to start in a couple of months this trial for patients with primary plasma cell leukemia, the most aggressive form of multiple myeloma. Now we have recently changed the definition internationally of plasma cell leukemia, and the idea is to treat this patient after a short induction with the CAR-T cells in first line, in the, more or less the same protocol as we decide in advanced phase, but adding the maintenance and probably to a shorter time between the first and the second dose. Beyond that, we have to do science, and we have many correlative studies also in the, for example, in the density of the CAR, evaluating the disease in peripheral blood mass spectrometry, or extramedullary disease by PET-CT, gut microbiota, the experience with centralized minimal residual disease, etc., and also going to a better potential CAR-T against myeloma than even RE2H, with using immunocheckpoint inhibitors, using a bicistronic bispecific CAR-T, changing some domains, or using CRISPR-9 for blocking some molecules, transcription factor, etc. And the idea is that altogether, we need a very heterogeneous group of people working from the preclinical to treat the patient, and also from the regulatory and the research management, that are crucial to the development of a so complex protocol. And for sure, we have to improve the efficacy, we have to improve the safety of CAR-T, but we have to improve also the access. And with that, I would like to thank all the donors. The ARI is called by one of our patients that unfortunately passed away some years ago, but that was the first initiating all these protocols. All the funders, particularly coming from the Ministry of Health, and also to all the centers involved in our trials and all our team in Barcelona. Thank you so much.
Thank you very much. This is a really amazing story, and we'd like to see how it proceeds also with other assets, other indications. Maybe just to remind one point, yesterday Stefan showed the timeline of our story as Miltenyi, and one of the important milestones was the first patient treated with CAR-T, CD19, and that was actually in Barcelona. So we are a long-term collaborator, and we are really happy. Any question? Yeah.
A quick question. Thank you very much for this presentation. How do you see peak expansion and expansion with the fourth dose, like the dose after 3 months? Do the CARs still expand, yes or no? And do you see reduced antigenicity of this humanized CAR? Could you comment a little bit on that?
Yeah, we could see expansion in 2/3 of the patients. This is smaller, always smaller, because all the patients had achieved in general very good partial response. Many were incomplete response. There were no disease in the bone marrow in general. It's impossible to say how was the antigen because there were no plasma cells at all. But the expansion is lower, and it was not related to the using of lymphodepletion, a second lymphodepletion regimen. That probably was more associated to the cells themselves.
Toon.
Thank you. Hello. Toon Oversteins from Miltenyi. Thank you for wonderful presentation and wonderful work. RE002, did I get it right? The cure rates in that 60 patient group you reported was 58%? Is that my understanding?
Yeah, it's difficult because in myeloma, cure is not the same that
It's not a
complete
real
response.
cure, yeah.
Complete response is
Correct.
60%.
Complete response,
But
yeah.
even, you know, that in all
Yeah,
therapies,
they-
in
yeah.
myeloma, unfortunately, the majority of patients in complete response will relapse.
Right. But how do you see the difference to handle with patients when they know and Google on the internet that Carvykti gives them what is published, around 80% versus this amount? So how do you manage that with patients?
Well, one of the points is the Carvykti is not reimbursed in Spain. That is the first. The best treatment that you can receive is the one that you can receive. That is the reality, no? Because we have cell that the results are less than 1 year in the median progression-free survival. We think that our strategy is also quite convenient in the sense of neurological toxicity, because it's extremely low or even absent, the neurological toxicity, when you compare to Carvykti, that is probably the most powerful drug that we have in multiple myeloma. But it's also, when you compare, no, for example, in this meta-analysis of the Memorial Sloan Kettering, is in the high, no, in the high rate of non-mortality, of non-relapse mortality. I think that is a space for this treatment. Anyway, even in Carvykti, we are not seeing a clear plateau yet, probably at least in this phase of the disease. And we know that this is another treatment, and we have to know how to sequence with other strategies in myeloma.
Final quick question: the 90,000 price, is that for the different? Is that for the whole package? You said the price is.
Yeah, it's for the production. Yes.
The full production of the different doses.
Yes, it's all. Everything is produced at the same time.
At the same time. It's frozen. It's cryopreserved.
It's cryopreserved always.
Okay, look.
It's up to 6 million of CAR+cell positive.
Okay.
The first dose is 3 million is fractionated,
Yeah,
and the
and
second one is unfractionated.
Got it. Thank you very much.
Hi, Maria Paola Martelli, hematologist, University of Perugia in Italy. I had always a question regarding using of CAR-T and bispecific antibodies in myeloma, considering the let's say chronic, anyway, continuous production by activated T cells or anyway activated immune system of IL-6. That is a well-known growth factor, let's say, for the myeloma cells and for the also the differentiation of the osteoblast to osteoclast and hypercalcemia. Is this being this considered in the treatment, in the I mean as a risky factor, let's say, of treatment, immune treatment of myeloma? And second, daratumumab, which is an anti-CD38 that now people start to think to combine with CAR-T, that is also an anti-lymphocyte, let's say, antibody. So how do you see these two risky factors?
Yeah, thank you. About the first, IL-6, well, we tried to treat patients with anti-IL-6 for years, even in smoldering asymptomatic multiple myeloma and symptomatic disease, and the results were very poor. No, we are not treating anymore. And it's true that it could be a complication. Probably the levels of IL-6, the one that we can be related, is a very high peak with the development of macrophage activation syndrome that could be more frequent in multiple myeloma than in, for example, in CD19 malignancies. That is the only point that probably we can link, we were able to link IL-6 with pathology or complication about this. It's true that when we are comparing bispecific or CAR-T cells, for example, the problem here mainly is that the majority of them are directed against BCMA. And our best sequence is to treat first with CAR-T cells, is possible, and after with bispecific at the time of relapse, because it's the right sequence, probably. And the second one was about daratumumab, yes. All the patients in general now are refractory to daratumumab. And in general, when we plan a maintenance phase or something to add some treatment to the to myeloma patient, we prefer either lenalidomide or pomalidomide, the immunomodulatory agents that can improve the activity of T cells, instead of bortezomib or daratumumab, because they can have some problem. Even we have a watch period. Now, for example, that we're using CAR T-cells in first line, the patient are receiving daratumumab. We try to limit the exposure of daratumumab before the apheresis, performing the apheresis before, because we know that daratumumab can last for months. In our proteomic studies in peripheral blood, the patient, we could identify daratumumab in peripheral blood even beyond 6 months of the treatment. Patients that were, for example, developing a CRS, 2 or 3, 10 days after the infusion, and we could identify still daratumumab of 6-7 months ago. That is a point that is evaluating. You need to perform, for example, in early phases before the treatment, or you can do it in the middle of the treatment, as we are doing in an autologous stem cell transplantation.
Thank you. So, one more.
Just a quick
Yeah.
question, yes. About the 4 doses, did you always succeed to manufacture the 4 doses at the expecting dose, like the 6 million per kilo? Did you always succeed to produce it?
To the 3 million of the first dose, yes, always. In the trial, we had 2 problems. One, we have to repeat 1 apheresis and 1 from a replication back, but otherwise it was. But all the patients received the 3 million. The second dose, they all had some second dose, but not always reaching the 3 million. It was 1.2 in some cases, 1.5, even the majority, I think the 85%, I think, we reached the 6 million of those. Now in the compassionate use program, sometimes you only have, with some patients, we have reached only the 3 million CAR T-cell dose. But the first one, for sure.
Always.